One of the questions I get asked the most about at the moment is what's the role of the PD-L1 biomarker in urothelial bladder cancer? The field has become increasingly complex. Essentially, what we have is 5 drugs with 5 individual diagnostic programs using different antibodies and different cut points to define the positivity. Some look at tumour cells, some look at immune cells, some look at both. The results we have available to us suggest, as it stands, that with the majority, but not all, of those antibodies, you can increase the response rate in the PD-L1 positive population. And the higher the cut point you define, it looks like that may correlate with higher responses. We're also beginning to get some data which is supporting the hypothesis that there are prognostic rather than predictive factors. And it appears with some of the drugs that the prognostic factors may turn out to be much more powerful than the predictive factors. And if that's the case in the single-arm trials, if you get very high response rates and great outcomes in the positive population, it might actually be because that's associated with the good prognosis patients. There's also some data at this meeting showing that cell cycle genes, DNA repair genes correlating with response to PD-L1. Now we know that they also correlate with response to chemotherapy, so we may actually be using these biomarkers to pick the chemotherapy winners as well. Clearly, if that's the case, when we do randomized trials, they're going to be challenging because we're going to get a population of patients who will have the winners in both arms. So to summarize where we are with the biomarkers, we started with a simple story. We started by measuring PD-L1. We showed response rates were higher. We then looked in more detail. It became increasingly confusing with the 5 different drugs, the 5 different approaches, getting contradictory results. It then got more confusing again when it became apparent that there was a difference between tumour cells and immune cell components. And now we're finding out the drugs are having prognostic rather than predictive effects. And so therefore, where we currently stand with the biomarker is there are more questions than answers. And one of the questions that we have to ask is whether or not we need to move on to a second generation of biomarkers, mutational burden, MSI high, second generation gene expression. And the likelihood is, in my opinion, we may need to move away from the IHC biomarker.